Hello, I'm Dr. Shu Yee, and my video is about getting behind OVD removal. This is a routine case of phacoemulsification with well-dilated pupil and good size intact CCC. This patient was planned for a monofocal lens. The IOL is first placed in a 1 and 7 o'clock orientation. OVD in front of the IOL is removed. The IA probe is positioned to nudge the IOL gently, and the IA probe is slide along the IOL edge in a scooping or pivoting maneuver to lift the IOL and remove OVD behind. Removing OVD behind the IOL can be daunting for beginners. Placing the IOL haptic at 1 and 7 o'clock position is helpful to create more space when nudging the IOL. I find this especially helpful for those starting out. OVD in front of the IOL is first removed to allow better visibility. The IOL is then nudged so that the IA probe can reach the IOL edge. With irrigation only, slide vertically along the IOL edge and lift the IOL in a scooping or pivoting manner. OVD behind the IOL can be safely removed with bevel up position. Once this maneuver is mastered, it can be repeated for IOL in different positions and of different designs. This is a case with slightly less dilated pupil with a good size CCC. 360 rexis margin is still visible. In the same manner, IOL haptics are dialed to 1 and 7 o'clock position. OVD in front of the IOL is first removed, followed by gentle nudging of the IOL to find the optic edge. Be careful not to push the IOL or stretch the CCC. Once pivoting technique is mastered, the surgeon can confidently remove OVD behind the IOL regardless of IOL type or position. This is a C-loop monofocal toric IOL. We first remove OVD in front of the IOL for better visibility. Then we gently nudge the IOL so that we can slide the IA probe along the edge of the IOL optic and position the IA probe bevel up behind the IOL for OVD removal. We can see here that because of better visibility, we're able to identify the remaining OVD behind the IOL that needs to be cleared. The exact same maneuver can also be repeated for different IOL designs as seen here in the double C-loop IOL. The same goes with plate haptic IOL. It is the same maneuver and the same principles. When starting out with OVD removal behind the IOL, always be on the lookout of certain situations. In cases of small pupils or small CCC, be wary to always ensure that CCC is intact. Always watch out for risk of pinching or catching the posterior capsule in cases of weak zonules or large bags. If unsure, always remember, first, do no harm. This is a case of routine phaco. During OVD removal, the IA probe bevel was positioned slightly sideways, and it inadvertently pinched the posterior capsule. This is a case where the posterior capsule already appears loose on cortical removal. We could observe posterior capsule striation. One has to be cautious during OVD removal behind IOL, as there is always a risk of pinching or capturing the posterior capsule. This was a phaco case with mid-dilated pupil. There was an undetected CCC tear at 4 o'clock intraoperatively. Because it was undetected, I proceeded with removal of OVD behind the IOL as per routine. The CCC tear extended into a large PC tear with obvious folds. It is pertinent to always be sure that the CCC is intact prior to going behind the IOL for OVD removal. In summary, OVD removal behind IOL is a useful skill to develop. It is one of the first steps towards embarking on toric and premium IOL journey. For starters, choose well-dilated pupils with well-sized intact CCC. Be familiar with the pivoting maneuver, and this can be repeatable at different IOL positions and different IOL designs. But always remember, always be cautious and first, do no harm. With this, I thank you.